Hey, it's Dr. Jay Calvert here. We have a little compilation episode for you this week. This is about facial rejuvenation starting from the neck up to the brow. And we've taken 3 episodes together. The deep plane facelift episode, we've got a mid facelift and fat grafting episode, and then a fox eye procedure episode, which talks about brow lifting. And we've taken some of the best information from those 3 episodes so you can get an idea of what we do when we do a total facial rejuvenation procedure, aka the natural lift. So enjoy, and if you want to listen to the individual episodes, just scroll back, you'll find them easily, and we'll be back with new episodes next week. The deep plane facelift basically is a lower face and neck lift where the SMAS, which is a thick layer of fascia overlying the facial muscles, the thickened part of the face that actually does the lifting to get rid of the jowls, etc. The reason it's important is how you address that SMAS, S-M-A-S is the acronym. It makes the difference in terms of the lift. You know, do you get a more vertical lift? Do you get a more lateral lift? Do you get a good vector? Or do you split it from the muscles of the neck? All those fine detail points are where the battle is won and lost in terms of the beauty of a facelift, because a lot of people can do a facelift, and as we know, you really see the bad ones and you can't see the good ones.
Right. That's the whole idea, is that you don't really know when someone's had a good facelift. That's kind of the idea. I mean, you can kind of guess because, you know, they're 80 and they look amazing.
Yes, that doesn't happen by the magic wand of Tinkerbell. It happens by the magic scalpel. That's right.
But, you know, I think any probably facelift done in the past 20, 30 years has done something to address the SMAS. That's not new. There's all different kinds of techniques to lift it, move it around in space. And that's like a whole textbook. And so it's not the fact that the SMAS is being treated so much that it's the way that we're treating it that's different with the deep plane.
Right. And so with the deep plane, it's a way to really get a good lift on the jowl, clean the jawline, and then also if you're able to split it from the platysma, because the SMAS, that thick layer of fascia, is actually contiguous with the platysma muscles of the neck. So when you kind of see these neck muscles when you're showing your bottom teeth.
Those bands that show on your neck.
People love those bands.
Ugh, I have so many.
I'm ready. You know, I just need to go. But the point is that the SMAS is continuous with it, so we wind up doing a little split of that muscle from the SMAS, and that's how we're able to get a clean neck contour, get the jawline, and lift the face. The reason that I wanted to bring up the deep plane facelift again is because I think people don't realize that it is part of a total facial rejuvenation. They think when you say deep plane facelift, it means that everything's deep plane. It means you're doing some sort of deep plane brow and some deep plane eyelids and some sort of deep plane lip lift or something. So that it's not. The deep plane facelift is, in and of itself, the lower face and neck. It's a jawline jowl procedure, you know, combined with whatever you're going to do in the neck, which there's many things to do in the neck. As well, and we could probably spend a whole podcast on just what we have available to do in the neck to make the neck look beautiful. But in terms of the upper face and the eyelids, you know, you and I prefer to do the entire upper face through very tiny incisions in the hairline, as opposed to many people who cut on the face, which, you know, we see that a lot, where the deep plane facelift ends at the sort of the level of the sideburn. They then carry the incision up onto the face, onto the side of the cheek, etc. That's not our gig. We don't do that. We can. It's just not what we choose to do.
Different technique.
Right, and we choose to make a basically 1-inch incision at the temporal crest on each side of the head, get down onto the bones, and do an endoscopic brow lift, mid-face lift, cheek lift for the upper face, which really minimizes the amount of scars that you see on a patient.
Right, and it really allows you to get down to the mid-face, to the deeper structures of the cheek, because a facelift alone, deep plane, whatever kind of facelift, lower facelift, like you said, addresses the jowls, the jawline, the neck, but it doesn't do a whole lot for anything above the cheekbones. So if your cheeks have started to fall, which everything does, you need a procedure to lift them. And the mid-face and the endoscopic mid-face does a really excellent job at lifting that cheek up and over. And so you're really getting a lift of the mid-face there as well.
Yeah, it's very powerful. In fact, one of my buddies who is a plastic surgeon in New Zealand commented on, I posted an 8-month video today of a post-op full facial rejuvenation, a natural lift. And his comment was, wow, you know, the volume looks incredible. How much fat grafting did you do? And I said, there's very little fat grafting. I happened to do some, but it was probably 8 to 10 cc's of fat grafting. What it is that mid-face lift really gets the cheeks to look rejuvenated. They look natural.
And full.
Full, beautiful. They don't look stretched. They don't look filled. They just look really nice, like, because it's the malar fat pad, this fat pad over the cheek that you're lifting up and putting into the position over the high point, the cheekbones, the zygomas, and man, does it look great.
Because that's where it's supposed to be. So, I mean, I say this
when you're 30.
Yeah, when you're 30, that's where it's supposed to be. So you can do all these fillers to camouflage the problem, or you can fix the problem. So the problem being that your cheeks have fallen. So how about we pick them up and put them back where they're supposed to be, as opposed to putting a bunch of fat or filler in there to camouflage it. So that's definitely all part of what can be done with a facelift. But it's, like you said, not just the deep plane. It's the deep plane plus to get you all those other things. So the mid-face is the area of the face between the lower part of the eyelid and like the bottom of the nose or the upper part of the lip. It's that junction that includes the lower lid and the cheekbone. And specifically, it actually includes that junction because that is a very distinct area of the face. Yeah, that's it right there.
I'm modeling it on the. If you're not on the YouTube channel, then you can see it right here.
Yeah, it's the mid face, and let's talk about why we have problems there, and then what we can do to address them.
Right, and the mid facelift is something that is near and dear to my heart. I learned about it as a young medical student when Rod Hester, Mark Codner was a resident, as a matter of fact, and Sonny McCord in Atlanta were really diving into doing mid-face lifts through the eyelid. And they were doing little canthotomies or canthopexes and cutting the orbicularis oculi muscle and elevating the mid-face to the temporalis fascia, which we have done. We've done all kinds of versions of this operation. We do mid-faces around Roxbury, like some people do breast augmentations in their office. We really do a ton. But I learned about it then, and this is in 1994. It was a long time ago. Actually, it was 1993, now that I think about it, because it was like October when I went to Emory. And I saw just amazing results with what they were doing. And it enamored me because it was addressing a part of the face that was traditionally kind of left out of a facelift. Mm-hmm. You know, they would do coronal brow lifts back in the day. Now we do them endoscopically. They would do the upper lids. They do the lower lids through the lid. Now we do them transconjunctival, and then we do the lower face and neck. But this part of the lower lid junction would often look hollow after that. And so that's where this concept of mid-face lifting really came out of, as a way to address a part of the face that was not getting the attention it deserved in terms of beautification and rejuvenation from a traditional facelift.
Right, because the problem here is that over time and with age, what happens is the soft tissues start to sort of fall off of the underlying bony structure of the face. So the fat and the skin that used to sit on top of your cheekbones starts to descend. So you start to get flattening of the mid-face part of your face. The other thing that happens is the lower lids. Sometimes you can see some fat start to herniate through the lower lid. So the lower lids get puffier. And so now you have this step off between the lower lids, which are a little puffy, and the fat, which used to sit right under them and support them, has now dropped, and you have this hollowing. So this is the hollowing that people try and fill with fillers, that they notice over time there's this hollow under their eyes. And it is simply related sometimes to genetics, but a lot of times also just to aging and gravity. That junction there is defined by a very distinct ligament, and it's not going anywhere. It is from the skin down to the bone. And so all of the changes that happen with aging really start to accentuate that ligament and that hollow. And so that is what is typically, as you mentioned, not always addressed in a classic facelift. Because a lower facelift is really designed to address the neck and the jowls and the jawline, but it doesn't really do a great job at lifting the central portion of the face, which is the cheek.
No, and in fact, the way that traditional facelifters address the mid-face is they make the incision come up around the tuft of hair in front of the ear and up onto the face, and then they lift it that way as a skin lift, or even even a little bit deeper than that. You can do it a little bit deeper, but it gets dangerous with the branches of the facial nerve. So I hate those incisions. I don't think it's any mystery to anybody about how I design my facelift incisions, because I know I can do an endoscopic mid facelift or a canthal mid facelift. So I don't like cuts on the cheek and temple, and that is sort of the thing that people would do, is a cheek temple lift. So what we're talking about today, though, is whether you need to fat graft the mid face to take care of the hollowing that you've been talking about, which is really important, or if you need to actually lift the mid face with an operation, because those are two ways that you can address it. And truth be told, a lot of people don't do mid facelifts. Yeah. This is an operation that is pretty rare, and it's part of the fox eye procedure that I do. It's part of the this is something that for me, it's like riding a bicycle. I love doing mid facelifts, and I think I have a TikTok that goes like, I love the mid facelift. Like, I'm just like enamored by it. But you don't always need to do that. Sometimes you can do fat grafting. And what in your mind, Dr. Rovelo, what's the differentiating fact that says to you, I should probably fat graft this person, as opposed to doing an endoscopic operation where I dissect through their whole face and lift the midface?
It really depends on the severity of it. I mean, if the tissues have really descended and they are super hollow, fat grafting probably is not going to cut it. But the other thing, too, is sort of what's going on with the lower lids. If there's something that's happening with the lower lids that needs to be addressed, it kind of makes sense to just go in and do the mid-face while you're there. Now, sometimes when you do a lower lid and say you have some fat that's herniating out, you can release the ligament that's really tying things down and separating the lid from the cheek, and you can redistribute the fat that's already there and sort of camouflage it. So there are some things you can do while you're doing the lower lid, but a lot of times combining the lower lid with the mid-facelift is really effective.
Yeah, I mean, that's, for me, you get so much out of a mid-facelift that's related to the lower eyelid. Yeah. You shorten the distance from the lash line to that tear trough or the dark circle. Like, people say, is there a treatment for dark circles? Yes, it's called a mid-facelift, and they don't want to hear that. They want to, like,
a little filler.
Oh, just can I just put a little cream on it and just get rid of it that way? No.
Short answer?
It's just, no. You can't. The dark circles, the only thing that you can do is make the dark circle smaller by elevating the cheek, releasing that ligament, getting, coming across that infraorbital rim and releasing all the tissues so that when you lift, that lower lid shortens. It gets smaller. And then your dark circles are improved because you've put your cheek tissue up where your, long eyelid, your L-A-L-L, your long-ass lower lid, I think that's what I was trying to go for, is now shorter. And so you want to do that lift, and you'll get great results with this. My patients love their mid-face lifts. They really are into this, and they like the fact that the lid is shorter. They like that the cheek is up. It usually is, combined with a lateral brow. It just makes you look better.
It makes you look better. And if you're treating this area as an isolated area, so if you're not doing a lower face, I think this is an excellent option. If you're already doing a facelift and the mid-face and lid cheek junction is not too bad, then fat grafting is actually not a bad option because you're already kind of redistributing some of the tissues, you're bringing them back up. So if a patient doesn't want to do the whole shebang of a lower face and a mid-face and an upper, and they just want to do the lower face and then throw some fat grafting in, that's a reasonable option as well. I actually like that option, I think, more so in men. You can certainly do mid-faces in men, but it definitely is a more, I don't want to say extreme, but it's definitely a different look because it, like you said, a mid-face is part of a fox eye procedure. It kind of gives you that more exotic, full cheekbone, kind of sculpted eyelid look. And some men need that, but if they don't need it badly enough, it can kind of feminize them a little bit too.
Yeah, I mean, it's all about the diagnosis. It's all about understanding what's going on, with the tissues. This is where, evaluation of your patient and what they are trying to achieve really is key. It's the understanding how to assess the tissues, assess their positioning, understand what your operation can do. There's a lot to it. And that's why I think when you're coming in for facial rejuvenation, the question should be, well, the first thing that the patient should really say is like, these are the things that bother me. And then what can you do about them? Not saying I need this or I need that, because you don't necessarily know that exactly. You probably have a good idea. Yeah. Like, I mean, there's going to be somebody who listens to this operation, be like, I want my dark circle shorter. I hear you. Right. I want a mid-face. So yeah, and that's it. But then it should be, and what else though? Like how am I going to look my best? Because these operations performed in a vacuum, one by one, doesn't always result in the best look for the patient. So you do have to kind of take facial harmony into account. You have to take the artistry of the procedures into account, and maybe you don't need a 4-lid blepharoplasty with every mid-facelift. I mean, maybe you don't need upper lids done. Maybe you need them done later. Maybe you don't need a lateral brow. Maybe you just need the mid-face. So it's like there's a lot to it, and it's all about what's going to produce the look that you're looking for. And as we always say, take a look at the before and afters on the website and the Instagrams, and on our Instagrams anyway. We've already hashed that out, that some Instagrams are truer than others, but on our Instagrams you can count on them being sort of the raw photos. This is where you get the information. You need to know, like, I want to get from here to here, and this is what I think. What do you recommend, doctor?
That's 1,000% how I do my consults for the face. I give a patient a mirror, I have them look at it, and I'm like, tell me what you don't like about your face. And they'll say, I don't like my lids, I don't like, this hollowing here, I don't like my neck, I don't like my chin. Great. Here are your options. This is how we can fix all of those things. And sometimes they're on board to do all of them. Sometimes they're like, well, let me just focus on the lower face. All of that's fine. Right. But they just need to know what their options are. And a mid-face it's not a nothing surgery. So if you're thinking about what your options are, you do have to know this is a very real surgery. It has very potential risks for issues and complications. So you have to know that this is a real surgery. It is going to be more than just putting some fat grafting. So not everyone's up for a big surgery. So all of these factors go into what the patient ultimately decides to do. I like the mid-face because I think that it, as I've said many times before, it corrects the problem as opposed to camouflaging it. I'm all about fixing what's wrong. The mid-face fixes it. Your face has fallen down. The mid-face pulls it back up. It's very simple.
Straightforward.
Whereas fat grafting doesn't do that. It doesn't fix the problem. It just sort of camouflages what's going on. So everyone's going to have their preference. Every surgeon's going to have their preference. And as long as you like the results of the surgeon you're going to, in some ways it doesn't really matter too much as long as they can deliver the results that you want. Why don't you introduce what is the fox eye procedure?
It depends who you ask.
Okay.
But typically it involves what's called a canthopexy.
Okay.
Or a canthoplasty. Mm-hmm. And the canthus is this little part of the corner of the eye where the eyelids come together and meet on the lateral, the out to the side aspect of your orbit, the bones around your eyeball.
There's also a medial canthus.
There is a medial canthus. We will not be touching that
No.
everyone knows, stay away from the medial canthus. But the lateral canthus is an area of beauty because some people's canthus, their canthi will go down and it makes them look sad. And when it comes up, it looks a little more mysterious, a little sexy, right? So
Foxy.
it's exactly right. So the fox eye is a term that's been ascribed to the canthopexy, and I do canthoplasty also. So the difference being, one is where you're tacking the canthus up to the bone with the stitch, and a canthoplasty is actually where you're cutting the corner of the eye and cutting the ligaments,
Making it shorter.
and reconstructing it and putting it up to the corner of the eye. And then typically, I think, based on my understanding, that the fox eye procedure in my world includes a lateral brow lift as well. So you're doing something to the canthus of the eyelid, of the eye, and then also the lateral brow lift. In my world, I tend to do a mid-facelift with it also, because I think if you're going to get the brow up, you should also get up the cheek, and that looks very sexy and very sultry.
Yes. So none of these techniques that you were describing are new or novel or not generally performed together. Like, these were literally the techniques that plastic surgeons have been using for decades to rejuvenate the periorbital area. So I guess my question is, who is either asking or getting this procedure? Because the combination of procedures you just described are what we typically use to address the aging periorbital area. Someone that's seeing some loose skin under the eyes, that's seeing their brows drooping, and they need to be sort of rejuvenated. So we do all of these procedures when we're doing lower blepharoplasties, mid-faces, lateral brows. Is there also a group of young patients that are doing it specifically to change the shape of their eye?
Funny you should ask that rhetorical question, because yes, and that is the key, because this is being done for people in their 20s and early 30s, just not as a rejuvenating procedure. It's not to make them look younger, it's to make them look better. And I've done this on 26-year-olds, 27-year-olds, 32-year-olds, and it's a way that, I think what's really given rise to this is the combination of fillers and Botox. So people do Botox, they get that little lateral brow lift, they do some crow's feet, and they get a little bit of lift at the corner of the eye, and they put some filler in, and it pushes the cheek up, and they're trying to get that fox eye look. Well, the surgical approach is a little more extreme, a little more permanent, a little more, it's just a little better. But I will say this, I have a patient that called me about sort of undoing their fox eye procedure. They were from back east, and they said, this didn't turn out the way that I wanted it to. And when I looked at it, they had like an ectropion, it just was done poorly, So you need to go to somebody who's skilled in the art of canthopexy or canthoplasty. Yeah. And I've done a lot of these, and I really like this operation. I think it's cool. I think the fox eye procedure does make people prettier. I think it looks awesome, especially if you get a good lateral brow lift and a mid-facelift with it.
Right. It brightens everything.
Yeah.
And just it opens everything up, even though the term is fox eye, but it does. It sort of brightens the area. I guess my question is, how much can you actually change the shape of a round eye to an almond eye with this procedure? Because we all do it when we do our lower blepharoplasties and we do the canthopexies. Tell all of my patients, for 6 weeks, you're going to look Asian. You're going to have a very slanted eye appearance. But we all know that doesn't last. And at 6 weeks, it comes down and you have a regular eye. So if you're really drastically trying to take a very round eye and make it almond shape, does that actually last, and does it work? And I can only imagine that to get it to last and to work, you'd have to do something really aggressive, cutting those tendons, putting them in really awkward, non-anatomic places, right? To get it to stay and dramatically change the shape of the eye.
Yeah, that if you really want an extreme change, your canthopexy needs to be aggressive, or you have to do a canthoplasty and cut the canthus and cut that lower lid tendon, which It's not a big deal. I mean, I do it. I used to do a mid facelift through the eyelid, you know, until I really got, you know, and this is like back in the day. You know, this was in like in the 90s. I used to do a lower lid mid facelift, which was a little bit harder. I mean, there were some things I liked about doing it because you didn't have to have an incision up in the hair. But now I do everything from up in the hair with an endoscope, and it's so powerful. It's so good, and you know, especially with the ability to use sutures and to use the Endotine devices that I use, no financial interest. It really makes a huge difference and it looks awesome. It changes the shape of people's faces to be much more heart-shaped and oval and
But are we changing the shape of the eye is what I want to get to. Are we actually changing the shape of the eye?
If you do it in an aggressive manner.
Aggressive.
You have to.
But if you do super aggressive, now you're really going to have problems. Potentially. I mean, this is not where you really got to go to someone who knows what they're doing around the eye.
If they know what they're doing, you're going to be fine because acanthoplasty is the treatment for all the lower eyelid problems that you can have, no matter how, you know,
which is why it's surprising that somebody got an ectropion after this procedure. Because by definition, acanthopexiumplasty is supposed to treat a drooping lower eyelid. So why do they now have a drooping lower eyelid after the procedure?
My theory is that they put the stitch into the wrong structures. They didn't get the actual canthus to do the pexy.
Right.
So there's also the term a negative vector lower lid. And this is something that, you know, we talk about at our meetings a lot, and it's a term that I think that the listener should understand.
Right.
The concept that your eyeball sits over your orbital rim, the lower
the cheekbone
bones of
for
your
all intents and purposes.
Yeah, but there's a cheekbone, and then there's that rim of your lower orbital bones, the bones of your eye socket. If the globe, the eyeball sits out over that rim, that makes you a negative vector, and
that is a tricky one to treat.
Hard.
That is hard.
Because then when you scar in, the lid tends to pull down and pull away from the globe, and you get what's called an ectropion.
Yeah.
The treatment, of course, being multiple things, but typically the first line of treatment is a canthoplasty. And so when I do lower lid surgery on negative vector patients, I tend to do a canthopexy, at least, if not a full-on canthoplasty.
Right. And that's where you actually have to be aggressive
100%
with it, because in the healing period, it's going to want to pull down and scar and pull away from the eye. So you really have to get that canthal tendon pulled up high, and they're going to look very Asian for a while. But you have to do that.
Yeah, it needs to be overcorrected at first, and that's okay. And you just tell patients, look, it's going to be a little high, and then it's going to come down. It always does. Now, to get that almond eye, you do have to, it's an artful procedure, and it looks cool, but you got to know how to put it in the right place. And I mean, I love doing this. If you talk to a lot of plastic surgeons, they're just not like we are. They don't love this. They don't love lower lid surgery. They tend to kind of go like, you know, like I'm just going to do a little of this, a little of that. I tend to dive in with both feet and, you know, get it going and just, you know, do what I got to do because I'm very comfortable with the lower lids. I did, you know, it's kind of all comes down to your training, doesn't it? It's like, what did you do in training?
With?
Well, when I was training in the University of Pittsburgh, airbags weren't invented. And so we had face fractures like they were out of style. I mean, on any given week, there are a couple, 3, 4, if not 5 severe facial crunches where acantoplasty was kind of part of the deal because we were exposing the cheekbone, we were exposing the orbital rims, we were putting everything back together with plates and screws. And the thing that you did when you put it back together was acantoplasty. You had to put the lid back together. And so that was just something we did a lot.
All the time. Right.
Nowadays, you know, you don't get these kind of fractures in. And so the training's different, you know, and if you want to get canthoplasties under your belt, you kind of got to go with people that do a lot of them. And there aren't many that do.
Yeah, this is definitely something where you want to go to someone who knows what they're doing, who does a lot of them, because the complications can be very real. And the complications themselves are very challenging to fix.
Yes.
So you don't want to have a complication because the treatment can be very intense to fix that complication. So any general plastic surgeon, for the most part, that does faces knows how to do a blepharoplasty, knows how to do a brow lift, that's literally what we do. But if you're really trying to go for like an aggressive correction to your eye shape, or you want to change it dramatically, I would say definitely go to someone who does it a lot, because that level of escalation and treatment needs to be handled by someone that does this a lot.
Well, I hope you really enjoyed the episode. Again, if you want to hear more, just scroll back, listen to the episodes individually. And next week, we'll be back with more information. So this is the Beverly Hills Plastic Surgery Podcast, coming to you from the 90210.